Thank you for answering the pretest. I'm Dr. Madeline Grace M. Sosa, a pediatric neurologist. Welcome to Mautak Man May Tama Din. The objectives of my presentation are as follows. Central nervous system infection can come in different forms. It can be meningitis, it can be encephalitis, and it can be meningoencephalitis, where meningitis specifically involves the meninges or the thin tissue layer surrounding the brain and the spinal cord, while encephalitis involves inflammation of the brain itself. When you have an involvement of both the meninges and the brain itself, we call this as meningoencephalitis. Central nervous system infection can come in different courses. The first is an acute infection, which usually lasts for less than 7 days, and this is manifested by your acute suppurative meningitis or viral infection. From 7 to 14 days clinical course, this is what you call the subacute CNS infection, and you can have here two conditions: partially treated bacterial meningitis and tuberculous meningitis. And the chronic form of CNS infection will be more than 14 days. And under this, you can classify them as TB meningitis, brain abscess, cryptococcal, or parasitic meningitis. Based on the DOH data, as of 2017, we have an emerging acute meningitis encephalitis syndrome. And in this surveillance, you can see that there are about 500 suspected cases reported from January 1 to January 3, 2017, and 27% lower as compared to what has been seen last year. What is noted in this particular distribution is that most of these infections, or about 25%, is seen in region 3, while 15% in region 1. And if you look at the slides, you will see that about 1% is present in our region, which is 4A and Mimaropa. Among reported cases with specimen collected, 8.52% were laboratory confirmed Japanese encephalitis, with other tested positive for other organisms like streptococcal pneumonia, micrococcus, and Neisseria meningitidis. These are the risk factors for developing CNS infection, whether viral, bacterial, or tuberculosis. These are the important changes in the epidemiology of bacterial meningitis. There's a marked decline in the occurrence of H. influenza meningitis. There's an increasing incidence of streptococcal pneumonia. There's an increasing incidence in antibiotic-resistant organisms, especially strep pneumonia for penicillin and cephalosporin. These are the etiology of meningitis at different age group. Among the emerging viruses, worldwide distribution is seen among herpes virus infection, such as herpes simplex virus. Limited to certain geographic area are your flavivirus, and what we have here in the Philippines is the Japanese encephalitis virus. Viral infections of the central nervous system can be either aseptic meningitis, encephalitis, meningoencephalitis, or myelitis. This slide shows you the different viruses and the severity of illness, which range from mild meningitis to fatal infections. When we look at the classification of viral infections of the central nervous system, we have to take note that meningitis, brain parenchymal lesions, spinal cord lesions are usually presented with an acute meningitis or encephalitis, or sometimes acute demyelinating encephalomyelitis called ADEM. Acute viral meningitis is meningeal inflammation that develops over hours to days. Most cases of viral meningitis are caused by enterovirus in 70 to 90%, and as what I have mentioned, mostly herpes simplex virus. there's an increasing distribution of Japanese encephalitis in Asia. And this slide shows you, the one in pink, shows you the different distribution of acute encephalitis in this region, specifically caused by Japanese encephalitis virus. The Japanese encephalitis virus is mosquito-borne fluffy virus. And like bacterial meningitis, it can spread through hematogenous route, contiguous route, or even direct inoculation. Other viruses can infect the central nervous system, and this include your polio, rabies, mumps, and HSV. On the other hand, this is the pathophysiology of bacterial meningitis. Bacterial invasion is via the hematogenous route. Therefore, this is followed by bacterial multiplication and induction of inflammation, leading to progression of inflammation and neuronal damage. As the bacteria enters the nasopharyngeal wall, it results into local invasions and bacteremia, subsequently leading to subarachnoid space inflammation, and this is responsible for the increased blood-brain barrier permeability, resulting into vasogenic and cytotoxic edema, as well as cerebral vasculitis and infarction, all of this leading to increased intracranial pressure. This slide will tell you that if you have a patient who presents with fever, with non-specific signs and symptoms like fever, cough, colds, vomiting, and CNS manifestations like headache, altered state of consciousness, CNS infection must be suspected. Whatever the form of central nervous system infection is, we have to consider the following as the important clinical manifestations: the non-specific signs and symptoms, the signs and symptoms due to meningeal irritations, and the signs and symptoms due to increased intracranial pressure. The non-specific signs and symptoms will include febrile episodes, headache, altered state of consciousness, skin rashes, even gastrointestinal signs and upper respiratory findings, while your CNS signs and symptoms will include cognitive dysfunction and focal neurologic deficits. For us pediatricians, it is always very important to us to consider several conditions that might predispose our patient or can give us a clue that the patient is having CNS infection, like the dermatologic lesions you see for meningococcal infection, the lesions you see in the mouth for herpes simplex encephalitis, and even seizures as well as headache. Koenig's sign and Brudzinski's sign are two very important meningeal signs that will give you a clue that the patient is having increased intracranial pressure or meningitis. The manifestations of acute encephalitis, usually due to viral infection, will include the following, and this, as you can see, is essentially the same as what you see with acute bacterial meningitis. Other clinical findings will include disorientation, behavioral, and speech disturbance, and even diffuse or focal neurologic signs like hemipharesis or seizures. Acute meningeal inflammation can be due to pia arachnoiditis or subpial encephalitis, and this is the reason why the patient will manifest with headache, neck rigidity, and meningeal signs, as well as changes in sensorium and seizures. Inflammatory or vascular and cranial nerve involvement are the ones responsible for ocular palsy, facial weakness, and deafness, while the pathology of thrombosis of the meningeal veins will be manifested as focal motor deficit, seizures, and aphasia. If the patient has or developed epidermitis or choroidal plexitis, this will lead into what we call hydrocephalus, while cerebellar and cerebral hemisphere herniation can result into quadriplegia and eventually cardiopulmonary arrest. During the subacute and chronic meningitis, other clinical manifestations like psychomotor retardation, unsteadiness of gait, and incontinence are actually due to tension hydrocephalus, while impaired alertness, refusal to eat, and persistence of fever are sometimes due to subdural effusion. Unilateral and bilateral hemiplegia is a result of extensive venous or arterial infarction, or what we call vasculitis. What about the late effects or sequelae? If the patient develops meningeal fibrosis around the optic nerve, spinal cord, and the roots, this can be eventually manifested as blindness, cortical atrophy, and spastic paraparesis, while chronic meningoencephalitis with hydrocephalus are usually manifested as dementia, stupor or coma, and paralysis. Persistent hydrocephalus in the child may eventually lead to blindness and arrest in mental development. Tuberculous meningitis, on the other hand, can come in different clinical stages. It can be stage 1, where you have meningeal signs with no neurologic deficit, while stage 2 will have neurologic deficit. And in stage 3 TB meningitis, aside from the meningeal signs and neurologic deficit, the patient can be in coma. When do we suspect acute bacterial meningitis? In infancy. The neonates and young infants may have different manifestations. They can have minimal or non-specific signs and symptoms like bulging anterior fontanelle, on and off fever, behavioral changes, incessant crying. And infants may be distinguishable from sepsis. Sepsis, which manifests with poor suck and poor activity, may also be a sign of CNS infection. Therefore, all neonates being evaluated for sepsis should also be evaluated for a possibility of meningitis. Diagnosis of CNS infection will be highly dependent on the clinical manifestations of the patients, the signs and symptoms, and the clinical course, plus several diagnostic tests which are very important to confirm CNS infection. These are the tests that we can use for patients whom we suspect to have CNS infection. Lumbar puncture is one of the most important diagnostic tests which will help us identify the presence or status of infection in the central nervous system. It should be performed in all neonates with sepsis and in all cases whenever the diagnosis of meningitis is known or suspected. However, lumbar puncture cannot be done on the following condition: presence of significant cardiopulmonary compromise, signs of increased intracranial pressure, suspected case of space-occupying lesion, infection in the area where the needle will traverse, hematologic problems, development of focal neurologic signs, and radiologic signs of increased intracranial pressure. This slide will tell you the different causes of central nervous system infection based on the etiology and based on the CSF findings. Other tests like serum C-reactive protein may be used to determine whether there is an infection or none. This slide will show you the different etiology of meningitis in the different age group. Likewise, polymerase chain reaction may be utilized to amplify DNA from patients with meningitis caused by common meningeal pathogens like strep, H. influenza, especially if the CSF culture is negative, and this is highly recommended. Latex agglutination test, on the other hand, is not routinely used in the diagnosis of bacterial meningitis. Procalcitonin is a good test to differentiate bacterial from viral meningitis. It is better than CRP. In situations wherein CSF analysis could not be done immediately, it may be used as a basis to start antibiotics. CSF culture and sensitivity is noted to be one of the most important confirmatory tests for the etiology of bacterial meningitis. Diagnostic tests for tuberculosis may include, of course, the culture and sensitivity, which shows 70% sensitivity and 100% specificity. Other than culture, you can also do polymerase chain reaction, which gives a sensitivity of 60% and a specificity of 100%. In this slide, you will note that the diagnosis of tuberculosis can also be made using what we call the gene expert, which can be done 1 to 2 days from the time of diagnosis, giving you a sensitivity of 96 to 100% and a specificity of 98 to 100%. Neuroimaging test is also very important in the diagnosis and management of central nervous system infection. It is rarely indicated in patients suspected with acute meningitis, but it is mandatory in patients with focal neurologic deficit or when you suspect focal infection. Example of this test are CT scan for job encephalitis, which can show, highlighted in this slide, lesions on the subcortical region. For streptococcal pneumonia, meningoencephalitis, you will also note edema on both hemispheres. For patients with open anterior fontanelle, suppurative meningitis can also be diagnosed based on cranial ultrasound, as you can see the enhancement of the sulci in this particular case, which is similar to what you will see on CT scan. Abscess, on the other hand, will appear as an ill-defined hypodensity on non-contrast CT scan, and a variable amount of edema is usually associated with lesions, and like tumors, they frequently are ring-enhanced with an addition of intravenous contrast material. This is an MRI showing the presence of ring enhancement in patients with brain abscess. Tuberculosis may also manifest as tuberculoma, as you can see in this magnetic resonance imaging, causing a highlighted or enhanced appearance of masses. Tuberculous meningitis can also manifest on MRI as basal enhancement, as you can see in this slide, as well as the presence of hydrocephalus. Fungal infection caused by cryptococcal and manifest as cryptococcal meningitis are also seen on MRI as enhanced lesions. Neurocysticercosis are seen as non-enhanced and enhanced CT scan, showing multified calcification of cystic lesions. So, brain imaging is important, whether it's cranial ultrasound, MRI, or CT scan, to investigate the possible causes, especially in cases of recurrent meningitis. Cranial CT is important before doing a lumbar puncture in patients with suspected meningitis. Neurologic signs and symptoms, which can include altered mental status, inability to answer 2 consecutive questions or follow 2 consecutive commands, focal neurologic deficit. In these particular cases, cranial CT scan was normal in 93 of these 96 patients. Alam mo, dapat hindi na yata ito kasama. Treatment. Antimicrobial treatment is given depending on the etiology of CNS infection. If the patient has CNS infection syndrome, is antimicrobial always required? Untreated or partially treated bacterial meningitis. It is, ano to? For herpes encephalitis and varicella, the drug of choice is acyclovir at 10 to 20 milligrams per kilogram per dose every 8 hours for 21 days, while for cytomegalovirus infection, the drug of choice is ganciclovir. This is the recommended empiric antibiotic therapy in bacterial meningitis based on age group. Management of CNS infection using different antimicrobial is also pathogen-specific, and this will give you the list of the drugs that we can use for several types of CNS infection, specifically bacterial meningitis. Brain abscess, on the other hand, will require antimicrobial. But the question is, when do you aspirate brain abscess? Number 1, if it's a single or multiple ring-enhancing lesions are found, the patient should be taken urgently for surgery. All lesions greater than 2.5 centimeters in diameter should be excised. And for abscesses in the early seborrheitis stage, or when the abscesses are 2.5 centimeters in diameter or less, the largest lesion should be aspirated for diagnosis and organism identification. Quadruple anti-TB medications like INH, rifampicin, PZA, streptomycin, plus steroids and surgery are the recommended treatment for tuberculous meningitis. Adjunct medical management in tuberculous meningitis for increased intracranial pressure include mannitol at 1 to 2 grams per kilogram per dose, or oraglycerol, or acetazolamide, or even repeated therapeutic lumbar puncture in patients with communicating hydrocephalus. What is the role of steroids in meningitis? Recent European study in adults suggested that dexamethasone is associated with a decreased risk of unfavorable outcome as well as decrease in the rate of mortality. Benefits primarily is limited to patients with streptococcal meningitis. What is the role of surgery? Surgery is indicated for patients with like epidural abscess, severe hydrocephalus as you can see in tuberculous meningitis, or presence of subdural empyema which results in compression of the brain tissue or parenchyma, and especially for brain abscesses in patients with HIV. These are the complications of meningitis, neurological and systemic or non-neurological. We have to remember that prevention is better than cure. Patients who have received complete immunizations will have the low risk of developing CNS infection, whether it's meningitis, encephalitis, or meningoencephalitis. And this will result in good outcome. Prompt diagnosis and early and appropriate intervention will result in good outcome. These are my references. Thank you for your utmost focus and attention. Please answer the post-test, all for the Filipino child.